Good morning, everyone. It's hard to follow Dr. Kinney's talk. And thank you, Beth, thank you, Dr. Sharma and Dr. Kinney, for giving me this invitation. I've been assigned to talk on the clinical advancements in structural heart disease. It's a pretty vast topic. I've been assigned 20 minutes, so we'll focus our attention towards aortic and tricuspid because those are the two fields where there's a lot of new things that happen, especially in the last few months. Moving on to first the aortic valve. The traditional risk stratification has always been as low, intermediate, and high, and extreme prohibitive risk in the past. But recently, since the advent of technology and new devices and new TAVR generation valves, it's always been deemed as either the patient is low risk or higher risk. However, we still follow the same surgical risk stratification score from the past. And if you look at the slide, although it's a busy slide, what it tells you is it's not just one thing that's going to help you decide whether the patient is a good candidate for surgery or transcatheter aortic valve replacement. It's actually a decision-making process involving the patient, involving the multidisciplinary heart team, and the multiple clinical and other anatomical factors, as simple as age, their risk, frailty, which is often excluded in all these risk factor models. And looking at the anatomy itself, the single most important assessment when we see these patients is actually getting a CAT scan and understanding how the valve looks like, and do we get enough or good valve expansion that one would expect or one would want to do after TAVR, and especially with the coronary and femoral access, because these patients can also have concomitant coronary artery disease, and there could be multiple valvular heart disease as well. So when we address these, so we have to take a whole set of criteria into consideration. And this is a graphical representation which tells us with the improvement in technology of the TAVR devices, the rate or the prevalence of TAVR has exponentially increased. We've seen the first bump in 2015 and then the recent one in 2018. And 2018 marks the first time when we actually see a slight decline in the surgical aortic valve replacements. And the two most commonly used aortic valves are the balloon expandable valve, it's called the SAPIEN valve, and the self-expanding valve called the evolute valve. And there are different ways that we can do TAVRs. The most common and safest route is the transfemoral route. However, we need to make sure that the anatomy is actually feasible, because you can do a good TAVR, we can deploy the valve, but patients' outcomes could be completely go south if we actually have any vascular complications. With the advent of technologies in peripheral space, such as cut down and intravascular lithotripsy, our transfemoral route is actually the most predominant one. It's almost 98%. But there are other routes through which the valve can be deployed. And there could be a transcaval, transapical is almost non-existent these days, transcarotid, and transsubclavian are the other routes. What are the most important complications that one would want to discuss with the patients and the family before you actually bring them to the TAVR? The big ones are actually the risk of stroke, because you're going to actually deploy a valve, and there is well-known data that there is at least 2 to 3% risk of stroke, and the stroke risk goes higher depending on the clinical factors. The second thing is the risk of PVL, meaning the valve is not sealing with the God-given native aortic annulus, so there's a leak between the TAVR valve and the aortic annulus. Why is that important? Because we know from randomized controlled trials that anything more than moderate PVL is associated with bad mortality and increased bad outcomes in as early as 30 days after the TAVR. And then the other complications, which are kind of rare because of the improvement in technology, is the heart block requiring a pacemaker and risk of contrast-induced nephropathy and bleeding. And more importantly, since now the TAVRs are being shown to have good outcomes even in low-risk patients, we got to consider them as a lifetime management, especially when we are offering them to younger low-risk patients, and understanding whether the first TAVR valve that we are going to offer them is going to be well expanded, what are the chances that it's going to degenerate or have any future problems that actually might be a problem for the patient. There are different kinds of valves, but the most commonly used valves are the balloon expandable valves is the SAPIEN valve, self-expanding is the evolute FX+, and then the navitor is the Abbott valve. So those are the three things, and there's a lot of things that we need to consider when we select these valves, which is the scope is beyond that's beyond the scope of this talk. But basically, you're looking at the CAT scan and understanding what is the size and what's the calcium content. Is there any risk of rupture when you use a balloon expandable valve? And most importantly, when someone has coronary artery disease, you can see that certain valves have a complex structure. So when they have a complex structure, that kind of excludes or makes you difficult in engaging the coronaries, especially if they already have a known coronary artery disease, or if they're a young patient, they might develop coronary artery disease in the future. So those are the things that we take into account when we do the multidisciplinary heart team evaluation. This is actually just a small table that actually helps the operators or the family members or the patient themselves to kind of select one way or the other. If you do if you're looking at doing a patient who's low risk and young age, balloon expandable valves are preferred. Why? Because they are not such a complex structure, and even if they actually degenerate in the future, the self-expanding valve can be put inside as a tab and tab. And if the patient has CAD, of course, you can see at the anatomy of the valve doesn't have any complex structures that actually inhibits you from engaging the coronary arteries. So we prefer putting a balloon expandable valve. Risk of coronary obstruction is the same. If there's calcium, we tend to go away from the balloon expandable valve because there's a risk of rupture when you go up on the balloon. The calcium can break up and bad things can happen. However, self-expanding valve can be encouraged in those patients. A valve-in-valve, the most important advantage of using a self-expanding valve is the hemodynamics. So historically, through the randomized controlled trials, the hemodynamics, which means the gradients, the velocities that you get after TAVR are better than a self-expanding valve compared to a balloon expandable valve. So if you're actually doing it in patients who already have a failed surgical valve, if you want better hemodynamics and if the anatomy is feasible, self-expanding valves are much better. And with regards to the stroke and risk of pacemaker, balloon expandable valves have a slightly decreased lower rate of stroke than the self-expanding valves. And balloon expandable valves have a less learning curve. So if you ask operators around the globe, they prefer using a balloon expandable valve because it's not very complex, the procedure itself, and it's almost like a balloon aortic valvuloplasty, except that you have a valve now at the tip of the catheter. So the learning curve and the experience is slightly better with the balloon expandable valves. This is just a sample CAT scan. This is what we look. On the left side, you can see how we measure the area and the diameter of the aortic annulus. And those two are the single most important determinants of what is the size of the valve that the patient can get or the type of the valve. On the right side, you can see all those white spots. Those are all the annular calcium. And then the one more important thing that you evaluate when you actually offer TAVR to these patients is looking at what is the left main takeoff from? Because when you put the valve in, if the left main is coming low from the annulus, the valve can go obstruct the left main. Or if there's a calcium chunk that can fly out and go and obstruct the left main. So those are the things that we actually pay attention to. And then we look at the valve selections. You can see in this case on the left side, nothing but it's all like a porcelain aorta. Like all those white spots that you see are not supposed to be there. So that's all heavily calcified. So in those cases, we tend to move away from the balloon expandable valve. And this one, we selected the navitor valve, which is a self-expanding valve. And the other important thing is to look at the axis, like how you can actually get the TAVR valve up to the heart. So you always scan the groin, and this is where if we actually pay more attention because complications can happen from here and bad things can happen if we don't pay attention and pay attention only to the aortic annulus. And the right side shows the aortic arch. Why is that important? Because, like I told you, one of the most deadly complications is stroke. We don't want, especially in a low-risk young patient, the last thing that you want to see is they have a stroke after the surgery. That's devastating to the family, to the team, to the provider. So we always risk assess these patients. How do the aortic arch look? And have a very well-informed conversation with the patient saying, the usual risk is 2 to 3%, but in your case, it might be slightly higher, or it could be lower. So, and there are certain things that we do during the procedure which will decrease the risk of someone having a stroke. There is something called an embolic protection filter, which is a device that goes from the wrist and sits right in the arch of aorta and the vessels, and that tends to prevent anything that flies out into the brain. There's not strong randomized controlled data that shows it actually is beneficial, but it does decrease the risk of debilitating stroke. So this is just, okay, aortic stenosis 101. But now you put all these things together. You have a young patient, or you have a patient who has bicuspid aortic valve, or the patient has severe aortic stenosis and the patient is completely asymptomatic, or the patient has moderate aortic stenosis and the patient is very anxious and want to actually know what are the options they have, or if the patient actually has concomitant coronary artery disease, which is a lot of patients actually have both CAD and aortic valve stenosis, or the patient actually has a failed aortic prior surgical or TAVR valve, or you have aortic stenosis and aortic regurg. I'm going to touch only the few things that are more common in our practice, which is, first one is the CAD and TAVR, so if, aortic stenosis. If you actually have both CAD and aortic stenosis, there is no still randomized data to help us guide which one we need to treat first. Should we treat the coronary artery disease and put stents and then do TAVR, or do we do TAVR first, followed by coronary artery disease intervention like PCI later? We don't have any randomized control trial data, but there's a big interventional registry that's from multinational authors that come from the Revas TAVI registry. They actually bin this into 3 groups. One group is the blue one, which is patients got stents before TAVR. The red one is patients got stents after TAVR. And the gray one is at the same time. At the same time meaning it could be on the table, the patient would have got the stent followed by TAVR as the same procedure, or a patient got TAVR and stents as on the next day before discharge. And you clearly see this is with the limitation of retrospective nature, you clearly see that the 2-year outcomes were better if you actually do the coronary artery disease PCI after the TAVR. Again, this actually has its own limitations of the retrospective nature, and there could be some critical disease that you may, as an operator, don't feel comfortable proceeding with TAVR first. So, but this is the only guidance that we got. And now we have a randomized trial that's coming up called the Complete TAVR, which we are also a part of, where we are randomizing all these patients to PCI first, followed by TAVR, or TAVR, just medical therapy. So don't do anything to these coronary disease. Medical therapy with the stents, and everyone gets a TAVR. And the mean follow-up is about like 3.5 years. This trial is in process. It'll be a very interesting trial to look. It will probably be completed in at least 3-4 years from now. It started 2 years back. And the next one is TAVR only for aortic stenosis. If you have a patient who have a aortic regurgitation, what could you do for those patients? So there's actually a couple of valves. The reason why the TAVR valve does not work well when you actually have no calcium is because there's nothing to anchor. Since it's only a transcatheter, we're not stitching the valve like surgery. So you need something to anchor the valve. So that's why there's new valve technology called the Jenna valve, where you can see there are anchors coming out. It's still not FDA approved. It's actually in trial, and this is something that patients can be offered for. If you have a mixed valve disease where a patient has some degree of aortic stenosis and aortic regurgitation, those patients we still can actually undergo regular TAVR, like routine TAVR. And this is the trial that showed that the outcomes were non-inferior. And there's another valve called the J valve, again, similar mechanism, where you actually have some hooks. The one thing that you need to know, if you have a patient with AI, you can do the regular TAVR unless they have some amount of stenosis component, because you need something to anchor the valve. If you don't have none of them, then you have to send them to these trials, places where they do the trials, which is the Jenna valve and the J valve. And then the next one is young patients. So we routinely see these patients, 40-year-old, 50-year-old, coming to the clinic and asking, I don't want surgery. It's going to affect my lifestyle. I come for the procedure, do the TAVR, I go home next day and start back with my life the day after. I don't want to go through surgery. And even if we tell them we don't have data that suggests that the TAVR valve does not last enough, they say, keep doing this every 8 years. It doesn't work like that, right? You can't keep putting valve inside a valve inside a valve. But so what the trial that actually looked up was a NOTION trial. It's a 10-year follow-up of low-risk patients, age less than 65, who got randomized into surgery versus evolute valve. And it was just presented in EuroPCR last year. It was actually pretty fascinating. If you look at the data here, there is no difference in mortality at 10 years for low-risk patients who are less than 65 who got the TAVR. So this shows that TAVR in the right patient population still can do as good as surgery in young, low-risk patients. But these are the other components that you need to look at, which is why the valve failed. Like whenever you have even instant restenosis, you need to know why the stent failed. The same way when the valve fails, you need to know why the valve failed. So there's more structural valve deterioration with surgical valve compared to the TAVR valves. And so I'm actually praising a lot about TAVR. But have we seen a lot of TAVR failure? Not a lot, but when it happens, it's not real fun. So you can see these are the pictures from the operating room when they're trying to explant the TAVR valve. On the top left is the balloon expandable valve, which is not as complex of a morphology, and the bottom is the self-expanding valve, and that's the self-expanding valve. You can see how nasty and ugly it could be, and when you're taking this out, you can injure the root, you can injure the aorta, and it becomes so complicated for surgeons. So TAVR has to be done carefully. It's easy, but it has to be done and offered to the right patients. When things doesn't go well, it is not good. So there was a registry that came out saying, looking at the explant to redo TAVR, meaning all these patients who actually failed their TAVR against a retrospective multinational, multi-center study done in the US. It was actually led by Gilbert, Dr. Tang from here, where they looked at patients who actually got redo TAVR and TAVR explant. Of course, the TAVR explant people did not do well. Their mortality within a month was 11% on the TAVR explant, and the redo TAVR was 3.4%. So this is a very important take-home message. And finally, does TAVR always need large bore access? Can we do like small French sheets? This was just presented last week in New York Valves, right here, by Pradeep Yadav from Atlanta. 8 French TAVR system. So 8 French, for people who are in the audience, to give a little comparison, that's almost similar to a cardiac catheterization where you put a stent through a 7 French system. So this is just a first-in-human feasible study that actually showed, because of the makeup of the valve, this is made up of rhenium, which compared to cobalt, chromium, and nickel, actually is much more flexible and can be crimped, at the same time have more tensile strength, and can be delivered through a small sheath. So this is a breakthrough technology, but still a lot of data has to be seen, but this is the future. This could be the future. And then the medications, if patients does not have an indication after TAVR to be on a blood thinner, we just put them on aspirin and Plavix for 3 to 6 months, depending on how they can tolerate. If they are on a blood thinner, say because they have AFib, then we do the blood thinner plus aspirin or Plavix for 3 months. After that, we can take the aspirin or Plavix off and continue just a blood thinner they were on for lifelong. So this is exactly what you need to have in mind when you see a patient or when you hear of a patient in whatever situation. Lifetime management of aortic stenosis. When you get a CAT scan evaluation for the first time, it's not just you're looking for TAVR feasibility at that time. You're going to see, if I do the TAVR now, and 10 years later, if this valve goes down, what could be the coronaries looking like? Do I have enough space to put a second valve in? Is this patient better off getting a surgery first and then get the surgery valve in valve in the future? So lifetime management is most important in patients with aortic stenosis. So aortic take-home messages: lifetime management, decision-making involving the patient, especially less than 65, more towards surgery. 65 to 80, case-to-case basis, more than 80, we know it's TAVR. And other subgroups of aortic stenosis that will need TAVR is pure AI, young age patients, or concomitant CAD and severe AS. And you need to stay away from TAVR in which patients? When whoever has a hostile anatomy, like bicuspid, severe calcium, or root dilatation, where you know if you do a TAVR, they are not going to do well, and you're putting them at more risk than what they are right now when you meet them for the first time. I have 35 seconds, so I'm going to go through fast for the tricuspid. All right, so tricuspid, we know it's often called the forgotten valve. Like providers, patients, everyone, tricuspid regurg, isolated, yeah, you have some leg swelling, yeah, who cares? Take some Lasix, you'll be fine. But the problem is, if this is not just a forgotten valve, but it causes more trouble. You can see that only 0.4% of patients are treated for tricuspid valve interventions, and they're associated with increased mortality. You can see that on the left, only 14% of the patients survive 10 years after they've been diagnosed, doing nothing to the tricuspid valve. And even if they do surgery, the surgery still remains, the mortality remains very, very high. The reason being is because, like I said, tricuspid is often the forgotten valve. By the time they come to you for the tricuspid, they already had a aortic, mitral, triple bypass, you name it. So they're probably second redo, third redo surgeries. They're not the best candidates. Unfortunately, they're not medically managed the best. So, and on top of that, tricuspid valve anatomy is also not easy. It's a very complex structure, and it's very anterior. So when you have an anterior structure, when you do a TEE, it's hard to image because you have a lot of shadow to actually gain that space and image, come all the way down by flexing the catheter and see the anterior structures. So that's the reason why in our program, all patients who are getting tricuspid clip, we do intracardiac imaging called the ICE imaging along with the TEE. And it's like 50 shades of gray, right? So it's not just one, tricuspid means it's not tricuspid all the time. It's almost all the time not tricuspid, actually. So it's mostly a bicuspid or quadricuspid or pencuspid, and it can come at different flavors, 2 of anterior leaflets, 2 of posterior leaflets. Why do we need to know all that? Because if you don't know this, you can't clip properly, and if you can't clip properly, you're not going to treat the tricuspid regurg. And this is, I'm just going fast. With regards to the tricuspid, there's only 2 mechanisms of this repair if you split them. One, there's a problem in the right ventricle because which the RV is stretched, and because of which the valve gets stretched. And now you have a gap in between the leaflets, and there's a leak. That's the most common cause. It's called secondary or functional TR. If it's a primary TR, that means that the valve has a problem in itself. The valve is flip-flopping, or most commonly, there's a pacemaker lead that goes through one of these leaflets. And because of that, the pacemaker leaflet is tethering the leaflet like this, and it's actually not making a seal. So that's more of a challenging situation. So that's one kind of repair where you put a clip underneath and you actually bring the leaflets together. That's called edge-to-edge repair. Those are the devices, the mitral clip and the tri-clips. Or like the TAVR, you put a new device in called the transcatheter tricuspid valve replacement. So this is the tri-clip system, which we use here. And the trial that led to this is the TriLuminate trial. And the primary endpoint, even though it's FDA approved in April, this trial did not show an improvement in hard clinical outcomes, meaning that if you do tri-clip, patients don't live longer. However, patients improve their quality of life. They can breathe better, walk a little more extra. So their KCCQ, which is actually a quality assessment of the patients before after procedure, and that was the only thing that was absolutely significant by statistics. And this is beyond probably more for the providers who do the procedure. How can we predict whether the procedure can be successful or not? It all depends on the leaflet. Are they healthy? Is there calcium on the leaflet? If I actually bring the leaflets together, can they rip off? If they rip off, then it's more trouble. And is the leak on the corner of the valve, that's called commissures? That's more challenging. But if the leak is right in the center, that's much more easy. So those are the things we look at. And this is the other one that we are about to start. This is called the EVOQUE valve, the third one. And it's actually also, it was approved first in February of 2024. The TriClip was approved in April 2024. And it's actually like a TAVR, but it's not as simple. Pacemaker risk is high. Patients need to be on blood thinners. And we're probably going to do our first set of patients next month. And April 2 was the groundbreaking where tricuspid clip was approved. And we were the first, actually one of the first, two hospitals, including us, did the clip on the first day when it was approved, us and Minneapolis Heart, and that was actually in April 4. So take-home messages for tricuspid. The tricuspid TEER devices are safe and effective in reducing heart failure symptoms and hospitalization, but no mortality. Most importantly, do not forget the tricuspid valve. Get them on medical therapy soon and get them to providers who can help them either GDMT or do procedures. And then imaging is very hard, so you need to have adjunctive 3D or 4D intracardiac imaging called ICE. Along with that, that'll help make you more efficient. And the valve replacement procedures, devices themselves, are still in evolution, and there's an exciting landscape. With that, I conclude, and thank you so much for your time.